Between the left atrium and left ventricle sits the mitral valve, acting as the rhythmic gate for oxygenated blood entering the main pumping chamber. In a healthy state, this pathway is broad. Blood falls easily into the ventricle, maintaining a low left atrial pressure of 6 millimeters of mercury. In mitral stenosis, this pathway narrows to less than 2.5 square centimeters. The smooth drop becomes a turbulent squeeze. The body demands a constant, high-pressure outflow to keep systemic circulation alive, usually around 120/80 millimeters of mercury in the aorta. Maintaining that forward cardiac output is biologically non-negotiable. To force blood through a restricted opening, the left atrium drastically increases its pushing force. When the stricture drops below 1 square centimeter, reaching critical stenosis, left atrial pressure must spike to at least 25 millimeters of mercury to maintain systemic outflow. The condition operates as a strict physical bottleneck, forcing the heart to sacrifice its own internal pressure gradients simply to keep the body oxygenated. Sustaining 25 millimeters of mercury takes a physical toll. The thin muscular walls of the left atrium are continually stressed, forcing the chamber to stretch and permanently dilate over time. As the cardiac tissue expands outward, it physically tears and distorts the heart's internal electrical conduction pathways. This structural distortion scrambles the electrical signals, triggering the chaotic, irregular rhythm known as atrial fibrillation. Instead of a coordinated, forceful squeeze, the atrium twitches. Blood ceases to flow cleanly through the chamber and begins to stagnate and pool. Stagnant blood rapidly forms clots. If a piece of this thrombus breaks loose into systemic circulation, it can travel directly to the brain, causing an embolic stroke. We can read this physical enlargement on an EKG. The stretched atrial tissue delays electrical conduction, creating a distinct double-peaked signature known as a bifid P wave. The mechanical necessity to stretch the atrium generates an immediate secondary crisis, widespread electrical failure, and systemic stroke risk. The circulatory system is a closed loop. Because the left atrium cannot contain that massive pressure spike alone, the physical force travels backward into the pulmonary veins. This retrograde wave floods into the pulmonary capillary bed, expanding the vessels and causing severe pulmonary hypertension. As pressure builds inside these microvessels, fluid is physically forced out of the capillaries and into the alveoli, the air sacs of the lungs, resulting in pulmonary edema. This fluid buildup restricts breathing, causing shortness of breath during exertion, difficulty breathing while lying flat, and sudden waking gasps known as a. These symptoms perfectly mimic left-sided heart failure. Yet, the left ventricle is completely healthy and functioning normally. It's simply starved of input. The pressure wave continues its backward march. It hits the right ventricle, forcing it to pump against massive resistance from the fluid-logged lungs. Over time, the right ventricular muscle thickens to compensate. Clinicians can physically feel this enlargement during an exam as a rhythmic lifting on the left side of the sternum, a peristernal heave. Eventually, the overwhelming back pressure. Blood leaks backward, creating a specific, high-pitched blowing sound called a Graham-Steele murmur. With the right side of the heart overwhelmed, the final dam breaks. The tricuspid valve regurgitates, and blood pools backward into the systemic venous circulation, visibly distending the jugular veins. This deep venous pooling forces fluid to seep into surrounding tissues, resulting in profound physical endpoints: a tender, enlarged liver, pooling fluid in the abdomen, and severe swelling in the legs. Massive structural destruction of the right heart and total systemic congestion are driven entirely by a microscopic stricture on the opposite side of the body. Because this specific physical bottleneck creates distinct fluid dynamics, it produces a highly specific acoustic profile that can be isolated at the bedside. On auscultation, the first marker is an opening snap. This sharp sound occurs when the restricted leaflets are forced open, confirming that the tissue is still pliable rather than entirely rigid. Immediately following the snap is a low-pitched, mid-diastolic rumbling murmur. This is the exact sound of blood violently squeezing through the tight stricture. The primary etiology behind this specific valve destruction is rheumatic fever, an inflammatory condition triggered by a prior Streptococcus pyogenes infection. The strep bacteria employ a protein structure known as the M protein. Our immune system creates antibodies to destroy it, but due to a structural similarity called molecular mimicry, these antibodies cross-react and attack the body's own heart valves. This immune-driven destruction creates the precise, pliable leaflet snap. It allows physicians to differentiate true rheumatic stenosis from clinical mimics like severe calcification or benign tumors that physically block the atrium. The mid-diastolic rumble heard through a stethoscope is essentially an acoustic echo of a decades-old bacterial deception. When treating mitral stenosis medically, physicians cannot repair the physical valve with drugs. The pharmacological strategy relies entirely on targeting the resulting cascade. Anticoagulants, such as warfarin, are deployed to manage the blood stasis in the left atrium, neutralizing the immediate risk of a stroke. Diuretics, like furosemide, are used to artificially drain the systemic fluid overload, relieving the immense pressure in the lungs and veins. Antiarrhythmic agents are introduced to suppress the chaotic electrical firing of the physically stretched left atrium. Finally, prophylactic antibiotics are required to defend the already compromised scarred valve tissue from secondary infective endocarditis. These 4 medications keep the patient alive by aggressively masking the retrograde symptoms, while the root mechanical bottleneck remains untouched. Absolute resolution requires physically breaking the 1 centimeter stricture to normalize the pressure gradient. The first intervention is percutaneous valvulostomy. A balloon is threaded into the heart and inflated directly inside the mitral valve to forcibly tear the restricted leaflets open. If the valve is too calcified or damaged, the ultimate escalation is the complete surgical removal of the diseased tissue and replacement with a mechanical or bioprosthetic valve. Mitral stenosis proves the rigid logic of hemodynamics, where a single centimeter of physical restriction dictates the survival of the entire human body.